Well, good morning and Happy New Year, everyone. Thank you for joining us for this conversation on clinical updates on our viruses that are circulating right now. And I thought I'd also add in a conversation about cough. As you know, I'm a pulmonologist, and I get a lot of questions every year. Why do I have a cough when we have viral infections? As you all know me, I'm also an internal medicine physician. I participate in disaster response, and I'm on the National Academy's Emergency Infectious Diseases Committee. And I also served as a CDC um, consultant when about 20 years ago they were doing the Faces of Flu campaign. And so these slides are from that campaign. And at a time when we were just trying to vaccinate anybody, we didn't even have a mandate for hospitals at the time to receive a vaccine. So this has been a territory that I'm very familiar with. And I've received many questions from folks regarding the fluctuating recommendations from the CDC. So we'll talk about some of that. We're going to talk about how flu happens, what are the risks, kind of how to prevent it, how do I treat it, how do I diagnose it, and some special considerations for our senior population, maybe touch on pediatric or pregnant patients. We'll decide depending on how time goes, and then talk about our current state. I would say we have a triple sources of viruses out there right now: flu A, RSV, and COVID. So right now, the flu annually causes 650,000 deaths a year. In the US, about 40,000 is an average every flu season. Over 200,000 hospitalizations, and then economic impact can be anywhere from 11 to $87 billion. In terms of cost of hospitalization, time out from work, productivity, you name it. This is just something that is what we have become accustomed to, but it's something that I don't like getting used to. We know that when influenza A, H3N2 circulates, pneumonias are spiking at the same time as flu A transmission. And we know that once you get flu, you're at higher risk for secondary bacterial pneumonia, and then that results in mortality. We also know that when children have influenza A, adults are more frequently hospitalized. Outpatient visits for flu are up to 250 times higher. Fever, cough, runny nose are all present in children with influenza. And this is just very common. And this is our cold and flu season. Kids can have a clear runny nose and feel bad and then get over it pretty quickly. Children are vectors of influenza A transmission, and they can spread it to infants, adults, our senior population, and then that leads into morbidity and mortality. And I should have just been clicking. Back in the 2001, the Japanese did a study on vaccinating children. And what they noticed is that it decreased all-cause mortality in adults following immunizing children against influenza. And that's led to the recommendations for immunizing children against influenza. But it also highlighted the importance of flu shots in everyone. So we're used to seeing morbidity and mortality every year. The very young and anybody over 65. I know that's considered elderly, but I'd like to say welderly, are at risk. Pregnant women are also at risk for influenza complications. So this is what an influenza A virus looks like. And it's got this lipid bilayer, and it's got these two different spikes. And they are kind of antigen, and they are used to help get the virus into our cells. The naming of the virus is by the type, A or B, where it started from, what strain it is, and the year it was isolated, and then those H's and then the N receptors that I showed you in the last slide here. So the H's and the N's. So that's why we see H3N2 right now. So that is how the flu viruses are named. Influenza B doesn't have the H's and N's, so it's just B where it came from in the year that they discovered that variant. So when that virus meets our mucosa, it attaches to our cells, and then it is what we call endocytosis or fusion into our system. It uncoats and unpackages. It releases its RNA, which viruses contain, and then it uses our machinery to then replicate and then create more virus and then duplicate in our system. We do have antiviral agents that then try to block this process. It doesn't stop. So if we give you Tamiflu, it doesn't stop this process, but it does stop the replication. So what happens is when somebody talks to you, coughs or sneezes, we always think that somebody has to cough and sneeze on you to spread infection. But studies have shown that if someone's talking to you for 15 minutes, you can actually get a significant viral load and of droplets, and they may not even know they have an infection. And they may not even know they have an infection. And the incubation period of influenza is 1 to 4 days. So somebody could have exposed you, and about a day or 4 days later, you may develop a sore throat, runny nose, congestion. So it's sometimes hard to pinpoint the event where that happened. I'm just making sure I'm muting folks so that background doesn't get recorded. You start shedding virus 1 day before you even have a runny nose or sore throat. Usually, the infection is isolated to our upper respiratory tract and the throat, because that is where the virus has entered our system. And then why do we feel a sore throat? And that is because our body and our system is trying to attack the virus and kill that bug, and it kills some of our own cells with it, and we get inflammation, and that causes our symptoms of a sore throat. And then we lose some of our respiratory defenses because of that killing process, and then that's how come the virus wins and goes down further into our respiratory tract. Sometimes we can look at these, I'm sorry this is a little blurry, but we've got some of the common cold viruses here. Rhinovirus, human Carinobacter, adeno, pertussis, metapneumovirus, flu, all are pretty much upper respiratory. Parainfluenza, influenza can go down further. And then RSV definitely affects the bronchioles. And then flu and SARS, which is our coronavirus or COVID, comes down further south. And that's just a general rule of thumb. but all of it can get mixed up, especially if your immune systems are deficient. And this is how your antibody responses after a flu shot help improve our immunity and prevent release of the um, virus in your system. So here is the time course that I mentioned to you of a runny nose, sore throat. This is very, very well studied. This is an old study where they injected medical students with influenza back when that was allowed to be done. But it's given us our kind of gold standard. They get infected med students with known influenza and then measured blood tests every few hours to see kind of where their immunity was. And they also measured viral shedding and described their symptoms. And the runny nose can happen from 0 to 7 days, sore throat the first couple, 3 days, muscle aches. That's one of our hallmarks of flu for the first 3 days. Headache is also associated with this. Many people are surprised when they have a headache with flu. Cough for the first 4 days, and a lack of appetite can happen through the whole course of illness. And it's about 7 days, the whole influenza cycle. But feeling bad can even extend into 8 days. You're shedding virus for the first 5 days, 0 days when you barely have symptoms, and up to 5 days. So it's important to know, even if you feel a little bit better, you can still be shedding virus. And here is another fever curve. Usually your peak fever is about 100, maximum 101 degrees. And you can have low-grade fever up to 7 days. And then here is our course of headaches, feeling bad, muscle aches, and then nasal obstruction, throat pain, and cough. What are some of the factors that implicate flu in death and secondary bacterial infection? It's our host immune response. And then we can get, if after 7 days you still aren't fighting the virus, you can get a secondary bacterial infection. But you can also see a primary viral pneumonia, and in rare cases, neurologic manifestations. So our vaccines. This is this year's vaccine. We do have only about 40, 50 million people vaccinated. And so it's not that many people are getting the vaccine. Most of it is from pharmacies and our medical offices. And, but it maybe, we'll see. I think you're going to see more vaccines get out there. Of people eligible for vaccine, 46% are vaccinated. And that's from last year's data. So we still have a lot of folks vulnerable out there. There are a couple of different types of flu vaccines inactivated. In the live, I do not provide the live vaccine. There's a trivalent that covers 3 circulating strains. The vaccine's usually available in October. They've started releasing it in August, and it helps us by making an antibody against those 2 surface proteins that I showed you earlier on the structure of the virus. These viruses evolve, and those N's and H's that I showed you are highly variable. What happens is that they look at what's happening in South America and Australia during their winter seasons and try to predict what's going to be circulating in the US by October, but they have to start making vaccine in March and April. And if there's some antigenic drifts where small point mutations occur, That's normal, and we have seasonal outbreaks, and that's something that I want you to focus on for the clade that we are right now seeing. If there's major shifts, then we can see a pandemic, and that's when in an animal host the H's and A mutate. So your H3 turns into an H5. Um, or an N2 turns into an N1, and that we weren't protected from. So this is the headline right now that is spreading across the US. This was on Christmas Day that I pulled, and this is from the CDC website. Below the headline is from Fox, and any headline right now is describing this aggressive flu strain. Well, it is an H3N2, which is the same thing I just showed you from the very beginning, influenza A, but there is a subclade K, which is that little point mutation, and which we have not been vaccinated against. It was a mutation that occurred after the vaccine was created. New York, before the Christmas holidays, was the hotbed. And I definitely received phone calls from folks in Texas, New York. And people still got on planes during the vacation. Remember, our children are a vector, and they arrived. And so we are seeing an uptake now in Southern California with influenza activity. This was in the formula this year. We have H1N1. We also have the H3N2, which is the influenza A that is circulating, but it's not the exact match. And then an influenza B. Here is the natural cycle of how the virus kind of goes through its recirculation, and how it can become a pandemic when it goes through a big shift and then enters our system. So our current strain is H3N2, influenza A, subclade K, and then this is its actual little point mutation here. And they're saying it's potentially more severe. I think the reason they're saying it's more severe is that people feel worse. Right now, as of a day or two ago, our hospital ERs are filled. The bed capacity is at max. The people are having trouble getting admitted. So we are seeing kind of a surge. But just remember that even though we may have like a lot of hospital capacity in terms of empty beds, but we don't have all the staff after the pandemic. So that's what also determines bed capacity. So just remember, if you do end up going to the ER or someplace, be patient. They're doing their best. Here is our vaccine composition, and this is the origin of that original virus and the particular strains. So I thought this was important for you all to see that there had been some thought in it. You are immunized against influenza A, H3N2, which is currently circulating, but we have that subclade K. So if you do get cold and flu symptoms, why is it important to know if it's influenza A? Well, it's because you can isolate, prevent transmission. We could avoid wondering or getting antibiotics for flu. I can start you on medicines for flu earlier. And we can, and if I test you well, we already know 90% of what's circulating is the predominant strain. So that kind of horses left the gate. The classic signs are rapid onset of symptoms, early non-productive dry cough, as I mentioned, headache. Some people feel like they've been hit by a truck. You can get chest burning. You can get light bothering your eyes, blurred vision, and just a persistent kind of feeling bad. Sore throat is a common symptom. Adults and children and our more senior population have different symptoms. So kids barely feel bad. They can keep running around. But our age over 80 can feel just very lethargic. Adults have more of a sore throat than kids. Um, Runny nose may not be present in our more senior population, but is very prevalent in our kids and younger adults. Cough, barely in children, but our age 18 to 65, that's a significant finding. So it's interesting how different manifestations of flu happen in different ages. Again, what distinguishes a common cold versus flu? This is something that we are not good at. If we just, I can't tell you how many times I get a call saying, I think I just have a cold, and it can be flu or COVID. There are home test kits, and we'll talk about that in a second. So we're not that good at distinguishing a common cold versus influenza. Factors that determine our course is our viral strain and the subtype. So these slides are almost 20 years old, but we're saying the same thing that we're saying today. We've known about this for a long time, our underlying immune status and our age. And this is again saying how bad we are at diagnosing. Only 38% were doctors able to even determine that if a person had flu based on just signs and symptoms. These are our times of flu season. And it is right now, November to February is what we're predicting is going to be our peak. We do know that as the temperature drops, our number of flu isolates increase. So that's something that is common. And we do see that out of season influenza sporadic cases do occur, but it's much less. But when the temperature drops, and if we've got some high level of community activity, then if you have a fever, cough of sudden onset, 80% chance you have influenza. So it's important for us as clinicians to know what's circulating so we can at least help isolate and diagnose. But luckily, we have rapid antigen tests now available over the counter. This wasn't present back when these slides were made, but we now have a combination COVID, home, flu A and flu B, all in one test kit. And it will give you results in 15 minutes. And you can have false negatives. That means that if you don't get a good enough sample from your nose, it may be negative and you might want to retest it. So I do recommend that you get stock up on that right now. They are available. I know Sharp Pharmacy didn't have them yesterday or over the weekend, but CVS and Walgreens may still have them. If not, just order them on Amazon and get them delivered to your home. And like I said, some detect multiple viruses, and we have them. Here's, if we put it under a spotlight, what a positive test would look like. Now, I like knowing what you have, even if it is just a rhinovirus, because it then tells me, you'll feel better in 5 days or 7 days or 10 days. I like to know within the first 48 hours if you have a positive flu test, because the antivirals that we have work best within the first 48 hours. If you have COVID, we have about 4 to 5 days to get you treated to have some effect. It also makes a difference. If you have flu, we're not going to recommend aspirin for kids. But basically for influenza and a Tamiflu plus bed rest plus fluids is important. Um, for disease prevention, vaccine if you're not already vaccinated, get the flu shot. Hand hygiene, cough etiquette, social distancing. I'll show you pictures of that later. Antiviral prophylaxis. If the person in the home is not vaccinated and is at risk, we can treat you. Studies are showing we can treat you with Tamiflu to prevent you from getting it. So that's something that's not common knowledge. And last week I did prescribe a family with Tamiflu after children were positive. So it's out there and we're seeing it, we're doing it. Walgreens had run out of Tamiflu. So that was a bit of a scramble for us. And we can have a conversation about Walgreens later too. Tips for infection control. This is what a cough looks like if you did a laser light picture. You want to cover your cough, throw out Kleenex, wash hands, stay 3 feet away. I would argue 6 feet, and don't share items. What are our complications? Well, influenza can land in our lungs and cause a pneumonia, but it can also cause a secondary bacterial pneumonia after about 7 days. Your own bacteria in your mouth and your throat can go down further. And we can see Staph aureus, strep, and Haemophilus are our most common. Kids, ear infections. And then if you used aspirin, Rye syndrome. Now, for my asthmatics or COPD patients or anybody with heart disease, we do see an uptick or exacerbation of those conditions. So that's what leads to our hospitalizations and ER visits, is the exacerbation of our chronic conditions. Prevention is vaccination. Vaccination of staff and visitors at hospitals, hand hygiene. And sometimes these are things that we forget. Even masking. Detect early, and we can give antivirals or to non-infected people who have been exposed. Vaccine effectiveness ranges from 34 to 46%, and that still holds. So many people are like, well, I got the flu shot and I got flu anyway. Well, yes, but we're trying to prevent hospitalizations and death. So it does help. Also, I receive a question about serial vaccination. So if you get vaccinated every year, you do have a little bit of antibody memory. So if there are little mutations, you are protected a little bit. So you do have some antibody response. In long-term care facilities, they gave once daily Tamiflu to people who are already vaccinated, and they saw that there was a 92% reduction in flu versus placebo. And in our nursing home populations, that'll be very important, but you can't give Tamiflu for months on end or even 4 weeks. That would be a little too much. So for our for Tamiflu, here's how it works. It blocks the release and replication of the infected virus. When you're infected, it'll block that release so that it doesn't replicate, but you still will have some cold and flu symptoms for a couple days, but then suddenly you'll feel better. Within 48 hours of symptoms, it will reduce the course of illness by 1 day. So a lot of recommendations are like, for healthy adults, they don't want to even take it. But when you're feeling bad, even 1 day early of feeling better is important. I think anecdotally, I've given it to my high risk cancer patients or people on immune deficiency therapies. I've given it at 3 and 4 days, and it definitely makes a difference. If you want it, you can take it. Here is what Tamiflu does in terms of its antiviral effect. If you gave Tamiflu and you tested the titers in the nose in an experimental H1N1 infection, it decreases the titers over hours compared with placebo. In children, less of an effect, but it decreased ear infections by 44% and reduced cough and runny nose and duration of fever. The interesting thing is parents always ask for antibiotics for their kids. Well, not as much anymore, but it did help reduce that request for antibiotics as well. And in children, here's that data on risk reduction of developing ear infections. And in terms of its resolution for flu symptoms, about 21 hours versus the placebo, an extra day. Time to return to normal health and activity, a day. And complications in antibiotic use, risk reduction anywhere from 20 to 60%. But this is important, 61% risk reduction for pneumonia and bronchitis. So in our high-risk population, we treat. What are the side effects? Maybe diabetes exacerbation, nausea, vomiting, diarrhea. Nausea, vomiting, diarrhea are the side effects of anything, even Tylenol. Early reports were some transient neuropsychiatric events in Japan, but we haven't seen that pan out after millions of doses. Let's talk about RSV because that's also circulating right now. We do see there's actually a home RSV kit as well that's separate from the COVID influenza. So if you can pick that up, it might be a good idea as well. In our common cold symptoms, we have cough, runny nose, sore throat, headache, as mentioned before. Maybe, and common cold, you can get a conjunctivitis or just with the respiratory common viruses. In flu, almost everything is checked, but no red eyes. Fatigue, earaches are common. But RSV, it's upper respiratory, and you get wheezing. And that's our hallmark of RSV, even if you've and most commonly people who've never wheezed before. Just 3-4 weeks ago, RSV and asthmatics result in hospitalization. Our children are at highest risk for RSV, and anybody with underlying pulmonary, cardiac, or immune system dysfunction. Our infants are at risk, and there have been some deaths reported this season. In our adults, low-grade fever, sore throat, headache, runny nose. So it presents very similar to flu, and that's why it's important for us to know the difference. We have treatment for children, but we don't have treatment for adults for RSV. RSV, there is a vaccine. Most of you have been vaccinated. It is licensed for age 50 to 60, but after seeing side effects, the CDC changed it to age 75 and above. Many people did get the vaccine earlier when it was first released in 2023. You are currently protected. There's only one RSV vaccine for pregnancy, and it's recommended to be administered in the last trimester of pregnancy. Here are, if you want the RSV vaccine, if you have any chronic conditions, you can request it. I've had some patients having a hard time actually getting the pharmacist to give it to them. But if you are on dialysis, have a chronic liver disease, any of these issues, you do qualify for RSV vaccine. It is best given. Many people asked me in the spring if they should get the vaccine. No, it's best given if administered late summer or early fall, but we may change that. This is kind of my prediction. Given the fact that right now the vaccine that was given in 2023 is still protecting our adults and they're not recommending any boosters, I would argue that any adult over the age of 65, 70 who hasn't received the vaccine should be able to get it at any time, and it will still last 3-4 years. Right now, they're not recommending any additional boosters because we're seeing that that vaccine has provided immunity. We don't know when it will wane, and we're watching for that. But this is kind of where the real-time experiment in this one. Co-administration of vaccine. As you all know, I am not a fan of it. All these companies, GSK, GlaxoSmithKline, they just want to say it's safe and you'll survive it. And they said that the reactogenicity was greater if you got the RSV vaccine alone. But it's similar to that if the Shingrix was given alone. This was double speak. They said, well, no specific safety concerns were identified. But if you look at the serious adverse events, 4.9% if you were given simultaneous administration of a Shingrix with the RSV vaccine versus 2.3 if it was given sequentially. So my thought is, why double the risk of side effects? And so that's why I recommend getting all our vaccines done separately, because you will get a better immune boost and reduce your risk of adverse events. And if you did get a reaction, how do we know which one you're reacting to, and then prevent the next dose? So I do not recommend co-administration of vaccines for all of these reasons. The only reason that people get co-administration is that feasibility of the patient returning for additional and patient preference. But we shouldn't hammer ourselves and our children with vaccines just because we're worried they're not going to come back. Currently circulating is COVID, flu, and RSV. This was the week ending December 20th. It's similar right now. Whoops, sorry about that. We are currently seeing a peak, or not a peak, just a rise in our influenza. It's still going up. It is anticipated the whole month of January is going to be still here, and it'll come down in February. RSV is taking a similar trajectory right now. COVID is about flat. I am seeing cases, notably folks who have been traveling, but all three are out there, so it's important to know. Let's talk about cough. I get a lot of questions about why am I coughing? All of the viruses we've talked about right now, flu, COVID, RSV, all trigger a cough response. And it's interesting for you to know that this is what your body does to generate a cough. It actually is a neural mediated brain activity. We can force ourselves to have a cough. We can't force ourselves to have a sneeze. So sneezes are a different neurologic pathway than a cough. But everything you can see, I'm so sorry about this. Our virus enters our nose and our upper respiratory pathway. It signals sensations to the brain, and that sends us back signals into our muscle fibers in our diaphragm, in our airway, and then creates a forced cough mechanism. If our cilia in our mucosa here sense a lot of mucus, it'll send signals back up to the brain to then tell us, squeeze the diaphragm, squeeze the muscles, and create a cough. So it's important for you to know that, because some of our medicines are acting really up here to stifle the cough. Management, in my opinion, as a pulmonologist, depends on what is going on. That's why I ask a lot of detailed questions. Are you wheezing What is the phlegm like? What is the color of the mucus? How thick is it? Is there any fevers? Is there any chills or sweat? Where do you feel the cough most? Is it from the sinuses? Do you have ear pain? Or is it from the throat? Or is it coming from the chest? And then we manage it accordingly. Um, Cough creates respiratory droplets, and that is important in terms of its infectious transmission. So our oral cavity is responsible for millimeter droplets. So a person who is speaking to you 10, 15 minutes can spread millimeters of droplets, and it can reach approximately 3 feet. And 15 minutes of conversation is enough for you to get infected. When you have a cough, the shearing forces can be up to 60 miles an hour of generated force. And what that will do is agitate our mucosa, and the phlegm that's been lining up and breaking down with the virus in our airways will then transmit. And that has been shown to transmit to 6 feet to 8 feet and high in the air around you. And then here is a detail in what happens with the airway opening and closing and agitating the phlegm deep down, so that then it all comes up and then out. Respiratory droplet transmission can happen contact, indirect, if you touch something that somebody's touched with their runny nose or cough because they put their hand in front of their mouth and then touch something and then handed it to you. And then you touch your nose and you just now got virus into your mucosa. And then droplet and airborne. This is probably our most common. And this is why you see Lupita and I masked. Because people may not even realize they're carrying a virus. And what we don't want to do is then pass it to you in this manner or this manner. And I know a lot of folks don't understand that when they come into our office, but we've known this for a long time. And here is how these droplet nuclei are formed. And they're, so I think it's just important for all of you to realize. Cough management. We do not have great drugs available. We've got Tylenol and dextromethorphan, and it is acting in the brain and it's sedating. And it does have lots of drug-drug interactions. There are some natural eucalyptus, menthol, that might help decrease cough and congestion. Echinacea may decrease risk of infection. Garlic, please don't use that. I haven't seen anything work there. Honey is actually a good cough suppressant, but we've seen botulism in children, so don't use it in kids. We've got ipratropium nasal spray that does decrease the runny nose, but can cause a bloody nose because of the inflammation and dryness. Probiotics, jury's out on that, but if you're taking antibiotics, it's good to have. Sudafed in our seniors, high blood pressure, stroke risks. So it's not something I commonly recommend. But if you have a sinus infection and you don't have blood pressure as an issue and you're young, you can take that. Zinc has been shown to decrease viral replication and shorten the duration of an upper respiratory infection, but please do not use zinc nasal sprays because it can lead to permanent loss of smell. So here's kind of my short list arsenal for acute cough management. There is something called benzonatate, which acts on the brain to help decrease cough symptoms. It just provides you a little break from coughing so that you can rest. Same with guaifenesin. Mucinex is just heavily advertised, a long-acting version of Mucinex DM that lasts 12 hours or maybe even 24 hours. It's worth a try. Studies have shown that it does kind of work. Albuterol is our mainstay if you have been diagnosed with RSV. Steroids, prednisone and a steroid inhaler if you have asthma or COPD and we need to help you decrease your wheezing. And if your sputum changes color after 5 to 7 days of a viral infection, I want to know about it. Or if you're at high risk, immune compromised, diabetic, you may have a bacterial, what we call co-infection, and you might need to take both antiviral and an antibacterial. It's important to know that cough can last anywhere from 2 to 12 weeks after a viral infection or a bacterial infection. And that may feel like a long, long time. As long as it's dry and you don't have a fever and it's gradually waning, that's okay. And with that, I conclude our conversation for today. I know there were some questions that were emailed regarding vaccinations, regarding the COVID vaccine. So I'll go ahead and address that right now. If you age over 65, you should have received 2 shots for the COVID 25-26 vaccine, one in April, one 6 months later in October. Now, if you missed the October dose, you're still eligible to get that COVID booster, especially if you're planning to travel. If you've missed your flu shot and you're feeling good, you can go ahead and get a flu shot now. It is being recommended due to our current uptick in flu cases. And with that, I'm going to go ahead and stop the recording. Thank you.